Hello, I'm Angela Large and I'm an adoptive parent with Family Futures, and I'm here today with Dr Raja Mukherjee, who is a specialist in fetal alcohol syndrome disorder. And this is our series of videos called Helping Families Heal, and we hope you find this information helpful. The questions are all from parents who've got lived experience of this disorder. So good morning to you.
Morning.
So would you just introduce yourself and what your sort of role is in how you work?
Okay, so Raja Mukherjee, you've just introduced me. I am a consultant neurodevelopmental psychiatrist. I've been doing that for over 20 years. The specialism of FASD came about when I was a senior trainee, became a research interest, then became a clinical interest, and then I set up 2009 the first national NHS-based clinic in the UK. There were other practitioners locally, but this was nationwide, where people would come and see us. And we've been working for the last 15 odd years trying to move the situation forward in the UK. And now there's a lot of other people doing work as well. When we started, it was just me. Or it felt like it was just me, at least as a professional. In terms of other things, because FASD is just one of my hats, is I'm the clinical lead for adult neurodevelopmental services. So the rest of my week is adult ADHD and ASD. So I'm a neurodevelopmental psychiatrist, and FASD is a neurodevelopmental condition. And so it has taught me more about all these other things than anything else, because it is a complex disorder which overlaps all these different things in the nature of how they present, and the links between them were part of my PhD, and so it's been something that stimulated me both intellectually but also clinically.
Brilliant. Well, I think we're going to come on to multiple diagnoses in the questions.
Which is why I mentioned
it. These questions are all gathered up from parents. So there was a lot around diagnosis.
Yeah.
So could you give us a brief idea of how you would go about diagnosing FASD?
The diagnosis is not a straightforward situation, which is whilst it's some people find it challenging. It is one where you have to rule things out as well as rule things in. There is a characteristic profile that we look for, and people, if you were trained, for example, before the 2000s, everything was about the facial features, everything about the stigmata that you look for, whereas we know only about 5 to 10% of people have that. And so the majority of people look typical and don't have other issues. We also know recently from work that I was involved with from colleagues in Canada that there are over 400 different conditions that this can present as. And so it's a very broad brush chemical which is causing damage to body, brain, everything. And so you can have a whole range of situations that it presents as, but not necessarily so. So you can't predict from one person to the next what it's going to look like. And so it is a complex evaluation. Now, we're a tier 4 specialist national clinic, and we do about 20 hours of assessment per person in order to do this. But what we have to try and do is, if we're going to see the numbers of people who exist out there, find ways of doing that more quickly, but still trying to find the domains. And so it's now been defined over many years what those bits and that characteristic syndrome looks like. Most recently, the Scottish Intercollegiate Network produced a document which NICE is now putting into quality standards, which will embed in the UK pathways. That is the approach that we take. Now, we had a consensus meeting a while ago to suggest that the Canadian guidance what we were going to use. That's what the Scottish guidance has built on. So it's been consistent over a while that in the UK, that's what we've done. And so effectively, you follow a standard approach, looking to find those bits that are inclusive, but also find enough information to say, I don't think it's this other thing instead. And so then you end up with a conclusion. This is the most likely cause of your presentation. It's always hard with psychiatric conditions and neurodevelopmental conditions to be absolute, because it's not like you're doing a blood test that gives you a specific number. And life isn't about you ever just having one thing. So you're looking for the thing that has the primary reason to explain your presentation, and understanding that there may be other things going on which modify it a bit, but this is the primary cause, and therefore that is the label.
Mm.
Now, one of the challenges that people say is that they don't understand the difference between a cause and an outcome. And this is getting onto some of your other questions in a sense, but it's relevant to diagnosis,
Yeah.
because what we're looking for here is what we call an etiological condition. And so that is the cause of the underlying damage that we talked about.
Mm-hmm.
And so it's been compared to conditions like Down syndrome, Williams syndrome, Fragile X, which are other causes of these neurological deficits. And why it's important is it guides you towards the other things to look for. It guides you as to how to modify your treatment processes in order to get the best outcomes, and it gives you an idea about long-term prognosis and what can be done differently. And that doesn't tell you everything about the individual, it never can.
No.
But what it does, it guides you to the areas to look for and what the complications are, so you can work out in a rapid way the whole thing. Or what you have to do is do the 20 hours of assessment on everybody, which is just not practical in the NHS. And that is why diagnosis and formulation go hand in hand, because one guides you and the other one tells you about the person. And so you do both together, and they take you forward to basically know what your child needs,
Yeah.
and therefore what you can do to try and improve the quality of life for that individual and their family.
Great. Very complex process. So it kind of,
It's no different to other diagnoses, to be quite
no.
frank, and it's the rational. It's just that it's doing it properly.
Yeah, yeah. I think that leads on to families' lived experience. They've adopted their child, and they start to notice some differences in that child. What are the things that people notice, or what do people come to you and say, this is happening with my child, or they go to their GP or whoever to start that process to get to someone like you who can diagnose that? What would they be seeing in their life, in their home?
So again, that's not a simple answer, because it changes with time, and so there's
Yeah.
no one thing. And so the first thing I always say is, just because you've got prenatal alcohol exposure doesn't mean that you're going to end up with a kid with FASD. There's a lot of
Right.
people, there's far more people who have alcohol exposure than kids who are diagnosed. And
Mm.
it's to do with having sufficient damage to cause a problem, compared to just having an effect which doesn't really modify itself. We all have issues. I'm mildly dyslexic, hasn't stopped me doing a PhD and writing a book, and so you just learn how to live with some of these things, and you get on, and it's just you, and that becomes the same. So you don't pathologize it. And so for the majority of people, you carry on living your life as best you can, and you don't do it. However, there are points in time where this becomes more common as a presentation. So those people who are the most obvious will present in the first year. They're going to present with physical problems, clear neurological deficits, but they're rarer. They're the ones that get picked up, and everybody can identify those. The next stage tends to be when you start to challenge the areas of difficulties and where that accommodation that parents naturally make are taken away. And so age of about 3, when you're going to nursery and you start to find that they're not interacting with the kids, or they're playing in an odd manner, and then it's not a typical, and when the teacher's coming saying there's something not quite right here, but you can't quite put your fingers on it. Again, primary school, about the age of 8, when you're starting to really study and they're starting to learn, and these kids are showing developmental delays and they're still further behind. The next stage tends to be when you go into secondary school. And it's not necessarily year 7, it's often year 8, because in year 7, they do a lot of support to start with. By that stage, you've got used to where you are, and you know where things have got to. But in year 8, you're expected to go straight away. You know what to do. And that's where it often falls apart. And you often hear that when they get to that start of year 8 or the end of year 7 is when it falls apart.
Yeah.
The next point where it can often present is later on into those teenage years, where the other adolescents are really rapidly developing, and these guys get stuck in that early prepubescent kind of phase. There's a lot of stuff where that social engagement becomes more obvious. The impulsivity and the difficulties and the vulnerabilities become exacerbated, and it's the behavioral presentations that people see come more to the fore.
So there was one parent said, my lovely, gorgeous little toddler suddenly, turned into this very difficult to manage
So the
child.
toddler
That's
goes at
your,
what stage? Is that the 3-year-old going to nursery,
I
where
guess,
suddenly
yeah.
there's social interaction, there's demands being placed on them, they're asked to learn, they're doing all this
Mm.
other stuff, they're being taken away from their lovely mum who's no longer there to meet all their needs, and the
Mm.
mum who isn't accommodating for that child. And all of a sudden, the expectations are you should be doing this on your own, kind of thing.
Mm.
And that's where the challenges come. So it's where the challenge comes. They can't cope, and it becomes more of a difficulty. And
Yeah.
it's where their issues become unearthed, so to speak.
Yeah.
Adulthood, classic presentation is when they go to university. Is that their families have scaffolded them the whole way, done all the preparation, done all the bits and support. They go to university, nobody's there anymore, all falls down. And that's something that you can see happens as well. So it's about taking away the support quite often, is when
Yeah.
you unmask the difficulties and the challenges that exist.
It's interesting that you've sort of noted those transition times, that's where it's where the sort of diagnose, where people notice things.
Well, if you think about transition, that's where we are changing expectations partly,
Yeah.
isn't it? And that's where, the what went before, because you can't stay life is the same. For most typically
Yeah.
developing individuals, transition is a part of progression.
Yeah.
But for these kids, quite often, where there is a difficulty and they can't manage that, it's what you're doing is unmasking an area of their abilities that need extra support. It's not that they can't function. It's not that they can't deal with that transition, but they just need more support, that transition that isn't there because nobody's identified it. What you'll find is if you identify it beforehand and put that support in, the transition can be managed well.
Yeah. Yeah.
Why it doesn't happen is that you don't put that support in.
Yeah.
In fact, you take it away.
Yes.
And then it all falls down. And that's what you see.
That's really helpful. Thank you. And I guess that sort of leads on to, you mentioned before that often diagnosis is very difficult because there's all, and you have expertise in other neurodevelopmental disorders. So one of the questions was, how do we, as parents, do we need to tease out those different diagnoses, ADHD, Asperger's, or autism, or and FASD, or is it more about accepting the child's in, putting in those supports, that support, so that?
So it's not that the diagnosis is impossible or impossible to do. It is done, and clinicians should learn how to do it. It shouldn't be parents doing it, to be frank.
No.
But the clinicians, neither are they experts in it all the time.
I don't think parents are trying to do it. I think they're just they've
trying
they're
to
looking at their child not coping, and they're wondering where to go.
So this is where you have to separate out what is a cause and what is an outcome. Okay, so let's look at it like this.
Yeah.
You've got causes of problems. You've got the brain and the body, which is being affected by those causes. And then once that is affected, you've got outcomes. Okay. And so the way I try and describe it, I'm quite visual, is that imagine a rock sitting there and you've come along with a hammer, and that's a cause, and you whack at this rock and you chip a tiny bit off, but it doesn't really affect the rock. Well, that's maybe one glass of wine for some person, and it doesn't cause much damage at all. Imagine a rock with a crack in it and you hit that and the crack splits a big chunk of rock off because you've got a vulnerability. That's why there's a thing. Now imagine two hammers, one to do with trauma, one to do with the prenatal alcohol, whatever, chipping away, and that's there. Now that rock then will lead to other situations. That's what's causing the damage. Now, if you have the damage and that chunk of rock falls off and it's caused by the alcohol, that's an FASD type presentation. The same way you're talking about Down syndrome as a genetic disorder. And the reason why nobody ever refuses to diagnose Down syndrome, because it's easy, not because there's any less issue or benefit to it. There is, you do a genetic test, they've got a very clear phenotype, so people are quite happy to make that, and they've never questioned the importance of it. There's no difference here. You are looking at that to understand the relationship between all these different things. So FASD is an etiological, it is a cause of the damage. Then you've got the brain processing, and we know with alcohol that what it is a white matter disorder. So the brain has grey and white matter, and when we're talking about how the brain processes, those areas of the brain where white matter is damaged, which is the linking bits, the fast connections, the support structures around it, that is damaged. So you basically end up with midline problems and interconnectivity problems. So you process things more slowly,
Yeah,
you
yeah.
don't link pieces of information, so you need more time, you need to have support to do all that kind of stuff.
Right.
And so then what happens is, if you damage bits of the brain where, for example, your social communication pathways are linked, you end up with autism. If you
Right.
damage the bits of the brain where you have your inhibitory control areas, you end up with ADHD. Now that's being simplistic,
Yeah, yeah,
but it's to do with how the brain is being affected and whether you've damaged it to enough a degree to get these outcome disorders. They're outcomes of
yeah,
that. And there are multiple things that lead to ADHD and ASD, because it's dealing with those things that cause damage to pathways, which is why from a genetics point of view, nobody talks about the cause, the gene for autism, or the gene for that. What they talk about now is the gene that causes damage to this pathway,
right, right.
because
That's
that's what you're
so
looking for.
helpful.
Because that's what you're looking for.
Mm.
Because what you're thinking about is ultimately these neurodevelopmental conditions are brain and body related issues. The body related stuff nobody talks about because they're actually quite easy to manage. Relatively speaking, you can deal with a GI problem, you can deal with those physical things because they're fixable.
Yeah.
The brain, we haven't found ways of changing it, so it's lifelong. And so
Mm.
you have to adapt around it. And these conditions are therefore more tricky to manage. You can do things to manage it, but it's not like the physical stuff, which have solutions for a greater part of it.
Yeah.
And so with these outcomes, what you're looking at is when the pathways are affected to enough of a degree, you will get this outcome disorder, which may be autism or ADHD. That's how it's linked. Now, for a lot of people, you may have slight damage, so you've got traits of it, but it's not bad enough to meet threshold. But
Yeah,
if you
yeah,
challenge that area enough, for example, you take all the scaffolding away, you're all stressed, and you shut down your functioning,
yeah,
which can happen to any of us,
yeah,
then that difficulty becomes a disorder, but it's not chronic. And so therefore it's not meeting threshold for some of these things. So it is about thinking about it, the relationship between these things, rather than they are separate. And the reason why we call them comorbid conditions is because they link together. And so that's the nature of how they are. And there's a lot of links that, because alcohol is such a wide, broad brush chemical, it does all these different types of things.
yeah. I think that's really helpful in terms of parents thinking about what they're doing in supporting their child. That really, really makes a lot of sense to me. I hope it does to others as well. I think we'll go on to sort of therapy and treatment from that, because it seems to lead on quite nicely. So some parents were asking what is available and other places they can go to find help if they think that their child has a FASD.
So if we were having this conversation 20 years ago, I'd say there was very little out there. Now things are changing. So, this is being done through Family Futures. You work Family Futures have started to understand ahead of many people that actually there's a link between those FASD brain related stuff and the trauma that goes on top of it, and that you have to do things differently in order to support that. And so there are groups now like Family Futures who are starting to do that. It's not unique to them, but they are clearly doing that piece of work in terms of trying to move that forward. We've just had we were funded by the MRC to develop a parenting program with my research group in Salford. That's now gone through the pilot phase, and the initial trials are very positive. So we now need to take it through to that. Once that's done, this will be rolled out, and you'll have a bespoke parenting approach for people with FASD to help manage in a different way, taking into consideration that brain and life type of issues around it. So you have a different approach. The Department of Health recently funded National FASD, which is the old NoFAS group, to produce with the Seashell Trust a website called My FASD and Me. That is another resource that is available for helping support individuals with FASD understand their own presentation. So it's an online therapeutic approach that allows you to work through almost an online workbook to think through their own presentation so they understand themselves. Because one of the key things with all of this is, if the person doesn't understand themselves, they're not going to make a change for
Yeah.
themselves. And so they have to want to do that, especially as they get older.
Yeah.
Because it stops being about the family, it starts being about them.
Yeah.
And they need to understand, and the earlier they start to understand that there are difficulties, you don't have to say you have FASD when they're 3.
No.
You know, you can do this in stages. You can say you've got things that you're good at and things that you find more difficult. We're trying to work on how to help you with the things you find difficult while building on the stuff that you're brilliant at. And that changes through to explaining as they get older what those things are, so they understand this stuff. Because the people who have the best long-term outcomes are the ones who themselves know that they need support and help. The ones who don't and don't buy into that are the ones who get into difficulties because they push back.
Yeah.
If it's seen as a parent who is just restricting me and I want to go and do stuff, all teenagers push back. My teenagers push back. And so but they're here, it just exacerbates their vulnerability. So it's about them understanding as early as possible, just simple things that protect people. So there was a family I used to know well in the FASD world who just simply taught their daughter, before you go and talk, she'll have to go and talk to anybody. She's just very chatty, but didn't get risks and vulnerability. So they just said, just before you go and talk to anybody, just tell us where you're going and just check with us. They embedded that. So, she would always check, can I go and talk to that person? And they would then keep an eye.
Yeah.
You know, and so it's not stopping the person, it's just having that thing that's embedded. So
Yeah.
you know when to do the extra protections and stuff. So it's changing. We're developing more stuff that is therapeutic and helpful, but you have to start with an understanding of this is the brain. This is the area that we have to understand first. Then you look at the layers of life that happen on top. So if you've ever heard me do a talk, you'll hear me talk about psychiatric onion, and it may be a psychological onion or whatever, because there's layers.
Yeah.
Underneath it in the center is the brain, how it processes and experiences the world around you, and then how life impacts on that. And all people with neurodevelopmental disorders process information differently. So you have to go back to what they process first, because if you use a typical model, you know, you're not understanding them, you're not showing them empathy, you're using your own perspective on the world to do that, and that doesn't work. So therefore you have to change change the situation to fit with that.
That's really interesting, because that leads on to something somebody asked about how to support their child as with the differences that they have. But you're saying the best outcomes are for people who understand themselves. And so really our job as parents is to talk about the difficulties and sort of help them understand themselves. Is that?
I think in a compassionate way. You're not doing it
Yes,
in
of
a
course.
negative way, but everybody's got strengths and weaknesses. Everybody has strengths. I'm mildly dyslexic. You know, I take longer to read than my kids. I take twice the time. Now I have to slow down, read word for word, and so, but I can do it. I clearly have. I've written loads of papers. I'm writing a book at the moment, so I clearly can manage it, but it takes me longer. And so everybody has strengths and difficulties. So what you're doing is building on their strengths and scaffolding their difficulties. But if the individual themselves don't accept or understand that there are challenges and this is normal to have strengths and difficulties, then they're not going to protect themselves as they get older when families take away the scaffolding. And so it's having those conversations in a way that actually allows that to progress through different stages while still supporting them to do it. And it's understanding what to do at different stages. So there's some stages in the individual's presentation, this can vary from day to day, where they take more responsibility. And then there's later stages in their function where, for example, they're hyper aroused, where you don't expect them to. And so therefore it is about having those conversations, but also knowing when not to have the conversations, because it's not always appropriate. So it's supporting them appropriately for the time that they're in. I don't know if that answers your question. Hopefully it does.
No, that's great. That really, I think that makes a lot of sense. Somebody asked a question about short-term programs for people with FASD. So she was sort of saying that if somebody with FASD has sort of short-term memory problems, what's the benefit of having, say, 6 weeks OT or, you know, because as parents, we're always looking for things to help, and the funding is obviously always an issue. So if a parent is feeling that they need some support, should they be sort of holding out for something a bit more long term, or do like a 6-week, 11-week program of something? Would that help, do you think, or is that something that is just going to get lost in the midst of time?
So the way I would answer that is short or long term in itself is not the problem.
Right.
You can do a year of therapy, but if the person can't engage with that type of therapy, then the year's wasted. See what I mean? Whereas if you do 6 weeks of something, but there's benefit at the end of it, then there's benefit.
Yeah.
And so it's not about the time length of anything. It's about having a structure, understanding what your objective is and how to reach it. You know, and sometimes actually you'll say, we're not going to be able to address the therapeutic need here in a 6-week period, so we need longer term. However, in an OT intervention, for example, where you're just trying to teach them skills that they can then be embedded and families can carry on, maybe that does have a benefit.
Yeah.
And so it's not about being absolute one way or another, because you're being too rigid in that sense. It's
Right.
about saying, is this going to have the benefit and the outcome I hope it will? Do we think this is going to achieve that, bearing in mind these individuals' different
I just
presentations?
realised that might have been a bit of a redundant question, given that you've just developed a parenting course.
Well, the parenting course is just a 7-week course.
Yes,
And so
but with
this is,
ongoing benefits.
but and that's the point, is that you have to start different layers. Our parenting course is designed as a 6-week intervention, as a psychoeducation course for all parents post-diagnosis. So
Right.
so they basically have
Yeah.
something to understand. These are the basic principles of managing it.
Yeah.
Not everybody will resolve with that. So some of those, if you say have 100% go through that and it works for 70% of them, then 30% may need to go on to have more specialist treatment, not 100%.
Yeah.
So your waiting list for CAMS, for example, are cut by 70%. Does that
Yeah.
make sense? And so it's about doing interventions that deal with different levels of need. And if the level of need, and so a parenting course like we've developed is a preventative strategy. You would hope that everybody gets it. So by learning the basic skills, it's the people who've got the most challenges, because there's more going on, that can get access to the specialist services, which are finite and limited, and where you need the longer ongoing piece of work, because most people don't actually need that, because a lot of the times it's about lack of understanding, it's a lack of knowledge on the space of that, and people haven't been given the right resources in order to manage these things going forward. And so it's having different approaches for different needs. It's not about saying the time limit is the right thing. It's not about an absolute, it's about dealing with what you need to deal with in the first case.
Yeah. No, that makes a lot of sense. There was a question about medication. I wonder if you could just comment on that, because they were in America, I think there is keen on medication, and it's not so used here. What would you say about that?
I would say America probably overprescribed, to be quite frank. There is no cure and there is no medication for FASD, full stop. Done, dusted, let's go away. There is no cure for it. What you're doing is managing the associated symptoms. Now, in the learning disability world, where I stem from, we used to have a thing that we talk about challenging behavior. We don't really talk about that anymore, because we don't treat challenging behavior. We treat the underlying causes of that difficulty, whether it's depression, anxiety, or whatever. And that's the key thing, is that what you deal with and what you treat is the associated presentation that needs treatment. So if it's ADHD, you treat the ADHD. If it's depression or anxiety, you treat that if that's a cause. And the medication you use is the appropriate medication for that presentation. Now, you may modify it based on dose, titration, etc. But what you're not doing is just giving a drug to sedate somebody, because that's not appropriate, and it's actually not right either ethically. Now, I used to have lots of debates with families and more carers in terms of residential care homes when I was started off as a consultant, saying, is this ethical? Because I would challenge people to say, medication, just because I can, doesn't mean it's the right thing to do. That's not to say there aren't times where it is the right thing to do, but it's having that conversation with the people around them and their advocates and themselves, if they're adults, to say, what are we doing? Is this the right thing? How do we do it in a safe manner, which is appropriate to treat the condition that's there, and not for just because we can, because
Mm.
that's what I wouldn't do. And I think America sometimes, especially also, without trying to be critical of primary care, they've got 15 minutes to see you. They want to do something.
Mm.
And so it's easy to give out a tablet where it's maybe not the right thing to do.
Okay.
I think in the UK, we tend to take that approach far more
Yeah.
necessarily than sometimes in the States, where, the situation is very different
Mm.
over there,
Yeah.
and so they are going to prescribe a great deal more. And they also have access to more medications as well. They
Yeah.
have licensed medications over there. We just can't get over here.
Right. Okay. That makes sense. Thank you. I think we've covered most things, but except school and education. So I don't know if that's something you can comment on. Obviously, schools are struggling right now, but in normal circumstances, often our children struggle a lot at school.
Uh,
So,
Well, everybody's entitled to education. SEN goes to 25. There has been work by people like Carolyn Blackburn, Barry Carpenter, and other people like that who've done work around how to access and support children with FASD in the classroom. Whether what they've done is used widely is unclear. But
mm,
there are other procedures and examples. For example, the mile approach, which was done about learning mathematics in America. Those kind of approaches can be adapted and used in the UK. There's nothing stopping that. End of the day, what you need is the EHCP to guide the families to what support's needed in the schools, what support's needed. But the problem is, if you can't get the assessment to get the EHCP, the health part of it, then you're not going to get the education part of it. Barry Carpenter was a professor of education. He used to say to me that, Raj, I'm more than happy for you to tell me what the problems are, but don't try and tell me how to teach it, because I'm the teacher. And I wouldn't, because I'm not a teacher in that
mm,
sense. I might teach university students, but um, certainly not in primary and secondary school. And
yeah.
so how the pedagogy works and how to apply that, I couldn't tell you how to teach it.
No.
However, there are approaches done by teachers as to how to modify the teaching for that. When they see us in clinic, we give some examples of where to look and the kind of adaptations that might work, but then it's for the education psychologists and the teachers to take the healthcare part of the EHCP and create the learning model that fits around the individual needs of the child.
Okay, so as a parent, it's pointing the teachers and the school towards those resources.
Yeah, the fundamental bit is the healthcare bit doesn't often work. So you don't get the pediatrician going in and supporting the family. When
No.
I had people local to me in my other work, with not FASD work, we would sometimes go and do AHCP meetings with
Mm,
families, but it needs the local person to support and do that, whether it's a nurse, a doctor, whoever. But that
mm,
doesn't always happen, and that's the challenge. Um, when you do an evaluation, because your resource is restricted, you've done part of it, but you've missed the other 5 things that are also relevant. And so
mm,
you need to understand, this comes back to the diagnosis question, about needing to look at the profile of the individual in
mm.
order to support the school as to how to get the right kind of help in.
Yeah. Well, that's great. And then we had some quite heartbreaking questions about, does this get better? But I think you've covered that in all your explanations of how the brain works and how the FASD interacts with, and it's about support, it's about understanding, and it's about giving the person themselves the tools to manage those things, those areas where they have difficulties.
So anybody who follows me on Twitter will have seen I've been using a narrative called #ChangeTheNarrative recently, because everybody focuses on the negatives, and these
Mm,
kids can be brilliant. They're really positive at times.
yeah.
Um, you know, the difficulties is society and individuals don't understand them,
Mm,
and they don't understand themselves, so difficulties arise.
mm,
Now, if we were again having this conversation 20 years ago, there was no support, there was no issues out there was no anything. And so the
mm,
narrative was very negative. We're in a different place. We've got quality standards from NICE coming out next year. We've got intercollegiate guidance from Scotland, which have been adopted. We have Department of Health funded specialist resources being created that are therapeutic and supportive for families and individuals. You've got places here like Family Futures who are doing work, understanding FASD, which wouldn't have been the case before.
Yeah.
You know, you've got specialist services and local services starting to show interest. Not that we're resourced.
No.
Hopefully that will change.
That'd be nice.
But you know, things are moving forward.
Yeah.
If you look at it as a cup half empty, you'll get depressed.
Yeah.
If you look at it as a cup half full, what it tells you is that we've got a long way to go, but we've come a long way.
Yeah.
So if we have this conversation in another decade, I'd hope the conversation would be very different in terms of the type of support. The people why people are negative is there's no support out there. People
Yeah.
didn't understand it. Whereas if you got the help, you wouldn't be so negative.
Yeah.
And so things are changing. How quickly they're changing, I suspect, isn't as quickly as we'd all like.
Yeah.
But they are slowly changing. And I think people need to hold on to that. And I think because I've been doing this so long, I can see the difference between where we started and where we're at now. And so it's a very different world for FASD than it was back then. It's not finished.
No.
Far from it. And by the time I stop, I would hope that that you're not needed. And that's the point, is that you have to get to the point where you've done your work, you can step away and other people can just carry on because it's done. But the way it's going, I'd hope that that was possible.
That's really encouraging, and that's good to know that all those things are being put in place sort of at the top, and hopefully will filter down as quickly to the families.
Fingers crossed.
Yeah. Well, thank you very much, Raj, for that.
You're welcome.
Really, really interesting and helpful. Thank you.
More than welcome.